So, starting the webinar, first I would like to give some background on our company called icometrix. It's based in Leuven, but also having an office in Chicago. It was founded in 2011 and has now a team of about 35 people. And we are committed to transform patient care by using imaging AI, especially for neurological disorders using MRI and CT. And for that, we developed a software called icobrain, which is CE marked and FDA cleared. And today it includes 5 reports for applications in multiple sclerosis, dementia, and traumatic brain injury. We have done a lot of work to achieve that, and this is built on also a strong scientific base of over 130 scientific publications. The work today will also show a lot of results that we did as part of the Center TBI project, which is one of the largest collaborative projects in the world for the research in traumatic brain injury. It's a European project that is almost coming to an end now, with already having some very nice results. So, showing shortly our current portfolio, the icobrain portfolio consists today of 3 main parts: icobrain MS to help the diagnosis and follow-up of patients with multiple sclerosis, icobrain DM helping the differential diagnosis of people with dementia, and then finally icobrain TBI, where we have a report for MRI, which is typically more in a follow-up session, or in the case of traumatic axonal injuries. And then the topic of today will be our report for traumatic brain injury based on computed tomography CT. And as mentioned before, at icometrix, we are committed to help improving the outcomes of patients with neurological disorders. And that's why we have designed these reports in such a way that they could contain information that would help the treating clinicians, like neurologists and neurosurgeons, to make better treatment decisions. So today we will be able to give you some introduction to the icobrain TBI reports for CT. This will be done by a very strong team, which is Thijs Vande Vyvere and his mentor, Professor Guido Wilms. So Thijs is currently PhD researcher at the University of Antwerp. He's part of the Antwerp Surgical Training and Anatomy Center, and he also works for the Department of Radiology in the University Hospital of Antwerp, and he is an employee of icometrix. And on the other hand, we have also Professor Guido Wilms. It would take me too long to mention all his accomplishments, so I keep it a bit short. He's professor in neuroradiology at the University of Leuven. He is former clinical head of the Department of Radiology in the University Hospitals of Leuven. He's a consulting radiologist for us at icometrix, and with his tremendous expertise, we have been able to grow our products, especially in the field of traumatic brain injury, where we can consider him as a worldwide expert in the imaging of traumatic brain injury. Moreover, he is an author and co-author of over 350 journal publications across his long-standing career. So I would now like to give the word to Thijs Vande Vyvere to introduce icobrain TBI as part of the clinical pathway for patients with traumatic brain injury.
Thank you, Dirk, for that nice introduction. So today I would like to guide you a little bit through the clinical pathway of TBI patients. And this is a simplified version, basically, of what happens when you suffer from a traumatic brain injury. So TBI is basically defined as an alteration in brain function or other evidence of brain pathology caused by an external force. And when you suffer from a traumatic brain injury, you go to the hospital, and then we look if there is a necessity for imaging. So there are 3 main reasons why we do imaging in patients with traumatic brain injury. The first and the most important reason why we do imaging is to detect or see injuries that require immediate surgical or procedural intervention. for example, large epidural hematomas or subdural hematomas. The second reason why we do imaging is to detect injuries that may benefit from early medical therapy or observation of the patient. And then the third reason why we do imaging is to predict the outcome of patients, which is important not only for the patient himself, but also for the family, so for family counseling and discharge plan. We look at patient management based on the imaging. So imaging will give you an idea of what to do with the patient. If there is a large hematoma present, for example, there needs to be some surgical evacuation or some other intervention. Surgeons will decide whether they put an external ventricular drain, craniotomy, or decompressive craniectomy. And then for early medical therapy, there's the possibility that the patient needs to be induced in a coma. Diuretics can be given for intracranial pressure management, or anti-epileptics or vigilant observation of the patient. Now, this is basically a simplified version of the clinical pathway. TBI is very heterogeneous and lesions can be different. Each patient is different, each injury is different. But this gives you a global overview of what happens to a patient with TBI. So let's zoom in a little bit on outcome prediction. So on the prognosis for the patient, we see that many of the imaging features or characteristics that we see in an acute non-contrast CT of the patient, non-contrast CT scan of the patient, we see that many of these features are used to predict outcome, and they are very powerful outcome predictors. So multiple scales have been developed to predict the outcome in these patients, which is like a cluster of imaging characteristics. The oldest one is the Marshall classification, which divides patients into 4 categories, and also a 5th and a 6th category where we see mass lesions that either they were evacuated or they were not evacuated, mixed density lesions that are higher than 25 milliliters or cc's. Now, the Marshall CT classification, it can give you a good prediction of the outcome in patients, but it's not linear and it has some limitations. For example, it doesn't make a distinction between the different types of hematomas that patients with TBI can have. Also, it doesn't take into account subarachnoid hemorrhage or the degree of cisternal compression, for example. So newer scales have been developed. For example, the Rotterdam CT score is a newer scale. It has been extensively validated together with the Marshall CT classification, and it contains a differentiation between hematomas. So it looks whether there is an epidural or subdural hematoma, extradural hematoma present. It also looks at the basal cisterns and the degree of compression of the basal cisterns, and it adds intraventricular hemorrhage or subarachnoid hemorrhage to the classification. More recent scales like the Helsinki computerized tomography score chart have also been developed. It has also been validated in a large data set now, and it reaches similar accuracies for outcome prediction compared to the Marshall and Rotterdam CT score, together with the Stockholm classification. So as you can see, multiple CT characteristics from the imaging, the acute imaging of this patient are used to predict the outcome. But what clearly comes back is that volumes are important in these cases. So mass lesions that are higher than 25 cc's. Midline shift also comes back a lot in these cases. So this is an important CT characteristic. And cisternal compression, which is basically an indicator of increased intracranial pressure. So for outcome prediction, these features are important. For patient management, for example, these volumes and midline shift, cisternal compression, all of these features are also important. So the outcome is worse, but it's also linked to how the patient will be treated. For example, epidural hematomas that are larger than 30 cc's should be surgically evacuated regardless of GCS score, according to the surgical guidelines published in 2006 in neurosurgery. But this can also be for other hematomas, for example, intraparenchymal hematomas. And there are certain guidelines how to perform surgery or when to perform surgery in patients. In addition, there is now a new scoring system developed, the NIRI scoring system or the NIRIS scoring system, the Neuroimaging Radiological Interpretation System for acute TBI patients, which uses CT characteristics or CT features to guide actually the patient management. So, and what we also see in these classification systems is that volumes are very important and midline shift. So you can be classified according to which kind of features you have on your CT as a TBI patient, and then a management will be suggested. So how are these features interpreted nowadays? Radiologic interpretation is basically mostly visual. So if you look at this radiologist here, he is looking at an image of an epidural hematoma, and he's measuring it basically, but it's not an actual measurement. So what we see also between radiologists is that there are differences in classification. This means that there is a lot of inter and intra-observer variability between them. It is difficult because TBI is a heterogeneous disorder, but it's quite concerning that there is so much observer variability in the classification of hematomas, so subclassification. Then the second thing is that the raised ICP features are also subjectively interpreted. So compression of the cisterns and the ventricles, this is done visually. Herniation and midline shift, for example. So there is also no actual volume measurement. At most, the radiologist will probably measure the length and the width of a lesion. And sometimes a method is used called the ABC method, which is an ellipsoid method, where A stands for the length, B stands for the width, and C for the depth of the lesion. So you can make an estimation of the volume. Now, this observer variability has been very concerning, and I will give you some examples also, some further examples of what observer variability can happen in station of CT scan. So on the left side, the two top images, you can see that these patients have subdural hematomas. When you measure a subdural hematoma, it also depends on which slice you measure it, actually, the length of the hematoma, but also the width of the hematoma. This inter-observer, it's actually observer dependent. But also the classification is different and can be heterogeneous. If you look at the right top image where you see compression of the cisterns according to the central review and the central TBI trial, but this was not considered a compression of the cisterns by the local investigator. So you see also in research differences between observers in whether they say there is a compression of the cisterns or not. This can be because of multiple causes, but for example, differences in background can be a reason. Neurosurgeons will probably be more inclined to not say that the cistern is compressed, but radiologists, they tend to report everything they see. So when we look at the midline shift, there are also 3 or more methods to measure the midline shift. According to the neurosurgical guidelines, midline shift should be measured at the foramen of Monro, but according to the common data elements, for example, that have been set by a group of experts for the radiological interpretation of TBI, they say that it should be measured at the level of highest displacement. So, and in radiological routine, there is also another method that is commonly used, which is to draw an ideal midline from the anterior to the posterior part of the falx, and then perpendicular to that line to draw a line that measures the shift towards the septum pellucidum. So this is also performed. So this means that even if you use semi-quantitative measurements like this, there are still differences in how what the number will be in the end. So we see that there's a lot of observer variability in interpreting CT scans of patients with traumatic brain injury in the acute phase. And there's a large concern, not only from the research community, but also for the clinical pathway, basically, to standardize this more and to quantify it more. So these are literal quotes from 2 papers from Yu et al. In Journal of Neurotrauma and Huff et al. In American Journal of Emergency Medicine, where they say that if you quantify CT characteristics more, it is possible to improve the outcome prediction of patients. And the poor agreement between radiologists and other observers is actually also alarming. And then Huff et al. Would say that this disagreement should be taken into consideration when integrating CT findings into the clinical treatment path. So there's a large suggestion for improved quantification and classification of structural injury in the head injury population. Now, the problem is that manual segmentation is not possible in an emergency setting. In addition, it is observer dependent, it's labor intensive, and it's too slow actually for clinical routine. So there is a need for a fully automated method on how to quantify these CT features that we are talking about. So here is where icobrain TBI comes into the picture, which can be integrated into the workflow. There is a quantification that is performed in the cloud and uses artificial intelligence, including deep learning algorithms for lesion segmentation. So a physician can send a CT scan to icometrix, which will be analyzed in the cloud, and then the results will be returned to the physician. They are then ready for interpretation. This is an example of a report for the new icobrain TBI CT product. And to show you what we actually can quantify, or what we quantify in this report, is the hyperdensities, the volume of hyperdensities, the total and the largest, for epidural hematomas, subdural hematomas, and intraparenchymal hemorrhages. We also quantify the volume of the cisterns, which can be an indicator of compression of the cisterns. We measure the midline shift automatically, and we measure the volume of the ventricles automatically, and give an asymmetry index, which can be an indicator of obstructive hydrocephalus. For the cisternal volume and the ventricular volume, we compare this to a normative population, and the hyperdensities, the cisterns, and the ventricles are returned into color-coded segmentations for the physician. So icobrain, compared to the ABC method, which is basically a volume estimation, and it's not necessarily a real segmentation of the volume, is very reliable already. We performed a preliminary study on 39 cases, where we see that the correlation between the manual segmentation and icobrain is actually better than the ABC method. And this is true for the different classifications of injuries as well, for epidural hematoma, subdural hematoma, and intraparenchymal hemorrhage. So this means that we have an observer-independent method that can actually help you to quantify certain CT features in traumatic brain injury patients. So now I would like to introduce Professor Guido Wilms, who is my mentor, and he will show some clinical cases with icobrain TBI.
Good afternoon. Let me welcome you on my turn in this webinar. I have the privilege to show and discuss with you two clinical cases that were studied with icobrain TBI. Let me make one very important preliminary remark. The purpose of artificial intelligence in medicine, and in general I mean, and of icobrain, in this case in particular, is not to replace the neuroradiologist, but on the contrary, to support and improve his report by offering some quantitative measurement. In the ideal case, the neuroradiologist has to check and double check the findings and the data provided by icobrain, to incorporate them in his report, and then to fully sign with his full responsibility the final report. Let's go to this first case. This is a case of a patient with subdural hematoma. And you see that there's a left-sided subdural hematoma, and icobrain provides us with a segmentation, an automated segmentation of the ventricles, of the cisterns, and of the hyperdensity, so of the hematoma. Now, in daily clinical practice, I would say here, and I would report this as a left-sided subdural hematoma. I would measure the width or the thickness of the subdural hematoma at the largest site. Then I would report that there is a midline shift, and I would measure this, measure the quantity of the midline shift. And as Thijs told you, there are different methods, and I will use my only method that I use. I will tell that there is a compression of the left lateral ventricle that is almost totally obliterated, but that there is also a compression of the right lateral ventricle that is less compressed to a lesser extent. And then I would look for some obvious subfalcine herniation and look if there is a transtentorial herniation. I have to confess that in daily routine practice, I don't separately score the basal cisterns, the cisterns of the brain, except if they are totally obliterated, because I know this has a very bad prognosis. Now let's look in this particular case what icobrain can offer. So icobrain says that there is a subdural hematoma and measures it at 73.1 ml. So this is highly above 25 ml. Then the cisterns are evaluated. Icobrain says that the supracellular cistern is within normal limits, but if we compare it to normal patients, to a normal population, severe compression. On the other hand, the prepontine, ambient, and quadrigeminal cisterns are a little bit compressed, but not significantly. We know that the left lateral ventricle is severely compressed, the right lateral to a lesser extent, but here icobrain offers us some quantitative information and compares this to the normal population, and therefore can say that there is a severe compression of the left lateral ventricle, which leads to an asymmetry index of 89%. Most importantly, the midline shift is measured at 9.4 millimeters, which is highly above the 0.5 millimeter score that is allowed for normal patients. This is then summarized in a graph that needs some training to be interpreted, which is called the security signature. But you can clearly see that there is a severe compression of the supracellular cistern, that the basal cisterns are preserved, and that there is a severe compression of the left lateral ventricle, in a lesser extent the right lateral ventricle. Now, of course, it is not the task of a neuroradiologist to tell the neurosurgeon what to do, but let's do the intellectual exercise to try to score the information provided by icobrain to the CT scoring system of Max Wintermark and NIRIS system. Here, that we have an extra-axial hematoma of more than 25 ml, which is score NIRIS 4, and therefore this patient should undergo one or the other neurosurgical procedure, probably drainage and evacuation of the hematoma. On the other hand, we know that this patient has a high risk for TBI-related death. If we look at the results of Bolak et al. Of 2006, again, we know that this patient needs an urgent neurosurgical intervention. And then finally, as Thijs told us, the Rotterdam, Helsinki, and Marshall score can be calculated based on the information provided by icobrain, and therefore the risk of mortality in this particular patient can be calculated. Second patient has, as you can see, an epidural hematoma. Again, icobrain provides us with a segmentation of the ventricles, the cistern here, the quadrigeminal cistern, and hematoma itself. Let's see what icobrain offers us. There is indeed an epidural hematoma of 40.4 ml, so more than 25 ml. The cisterns, as well, the supracellular, as well as the prepontine, ambient, and quadrigeminal cistern are severely compressed, quadrigeminal to a lesser extent. But as you can see, compared to normal patients, the supracellular and prepontine cisterns are almost obliterated. Again, the ventricles, here in this particular case, the right lateral ventricle is almost totally obliterated, while the left lateral ventricle is severely compressed, leading in this patient to a negative asymmetry index because of the change in site of the hematoma. The midline shift in this patient is 4.3. Then when we go to the security signature, again, we see that all the basal cisterns are severely compressed, as well as both lateral ventricles. If we go to clinical decision-making and outcome prediction in the NIRIS score, we see that again, there's a NIRIS 4, and this patient should have a neurosurgical intervention. I do not fully agree with the statement that this patient has a high risk for TBA-related death because it occurs that epidural hematomas can have a better prognosis than subdural hematomas. Again, Bullock et al. Say that circle management is indicated, and we can predict the mortality, the risk of mortality by the 3 offered scores.
So with that, we would like to conclude our clinical cases, and I would like to also try to give a conclusion of what icobrain TBI tries to do. We try to bridge the gap between clinical practice and the CT scoring systems, because thanks to the CT scoring systems, I think the management of patients could be in the future more standardized, and that together with the quantification allows for a standardized interpretation in the crucial acute non-contrast CT. And with that, we believe that this allows for a better management of the patients of acute brain trauma, and hopefully that leads to better outcome. So we're still at the early side of that. Much is still under research, both from the CT scoring system side as well as from the quantification side. But I think both sides are evolving fastly thanks to the very large research collaborations that are ongoing. And I think that will be for the good of the patients in the near future. So I would like to end with showing some of the references that are important for this webinar. They are there for your reference. So I would like to take this opportunity to thank you all for your presence. It's again fantastic to see that many people are attending. So thank you so much for being present. And we would like to welcome you for our next webinar in more or less a month from today. So thank you again, and hope to see you later.